And leukemia is a stem cell dysfunction in the hemopoietic stem cell, or around about a few cells here or there. And they are AML and ALL, and the chronic leukemias like CML and CLL. Lymphomas, again, are the ones that affect the lymphocytes, again, and they are differentiated further down from the hemopoietic stem cells further down. And they affect the lymphatic system. And there's a whole range of lymphomas that depending on the B and the T repertoire. Myelomas are, again, B-cell dysfunctions. And these are the common things that you see. Blood disorders, again, could be stem cell dysfunctions, which are non-malignant in nature, but again have very serious deleterious effects on the organ growth. So thalassemias are disorders which have hemoglobinopathies. Aplastic anemia is not a cancer. However, it behaves very much like a cancer and deserves a bone marrow transplant. Sickles and CALS are all together. Fanconi anemias and other genetic disorders like congenital anemias, diamond black flan, and all the others are again inherited or other congenital bone marrow disorders which deserve transplants. So generally, when we treat tumors of solid or hematopoietic in nature, we give them chemotherapy to debulk the disease, try and bring them down to a point where we can handle them, and do radiation therapy where there is indication and data. And different kind of these diseases which you heard about before have different prognosis because the severity depends. And leukemias are probably the worst things to have. And among the leukemias, if you have an ALL or an AML, they are difficult to treat and probably one of the worst diseases to treat on the planet. So these won't help there because chemotherapy and radiation will not prevent the stem cell dysfunction from recovering. Albeit might be able to keep them on a low ebb for some time so that they don't relapse. But eventually, microscopically, even if the marrow is clear, there's always one cell that would be here or there. You might not be able to prevent the entire microscopic burden, or what you call the minimal residual disease, away. And they always relapse in AMLs and ALLs if you don't give therapy which is appropriate for their staging. Mind you, all AMLs and ALLs do not require allogenic stem cell transplantation. It is the intermediate risks or the high risks which do need it, and the low risks can be managed without an allogenic transplant. Next slide. So, like I was saying, if we can find a match, we can do a transplant. So what do we mean? So conventionally, you all are aware of how we do renal transplants and liver transplants. In a renal transplant, you have a donor, you take a kidney and you put it into the recipient. You kind of make sure that there is matching of blood group to whatever extent, and matching of the HLA as well. But very often you see that the donors are the wives, because those are the ones that really care and are willing to go through the entire turmoil of giving a kidney, or their mothers. So usually allogenic donors in these kind of solid tumor disorders, like in liver, they just go with what they have. But when we go to a hemopoietic stem cell transplant, the degree of hemopoietic HLA requirement for a match for this graft, when you say a graft, it's almost like when you cut a rose and graft it into another. It's just like that. So we call the donor's organ a graft. And when you take this graft and put it in, the HLA mismatch has to be as minimal as possible, because marrow is the site of immunological reactivity, and the T cells are primed to kind of make sure that nothing foreign comes in. So you need the closest match to come in. So here's the trouble. How do you find the closest match? So before I do that, let me tell you a bit about what stem cells are. So adult stem cells and embryonic stem cells are two different kind of clans of stem cells. Embryonic stem cells are when a sperm and an ova meet, and you have a zygote, and you have a morula, and you have this embryonic disc. These are cells which are embryonal. They have multiple fascinating properties because they prime to differentiate into different organs depending on what kind of priming stresses come. So embryonic cells are out of question. We don't use them as cells, so we don't do that. So we use adult healthy stem cells. All the organs have stem cells. Liver has stem cells, lungs have stem cells, skin has stem cells. So they all renew constantly, and but not at the rate at which the bone marrow does. The bone marrow stem cells are constantly in hyperdrive, trying to make sure that there is a balance between what's going on in terms of supply and demand. So You can also have an umbilical cord stem cell, which is again embryonal, but is available for us to harvest because there is no harm done there. And all of these can be used depending on what kind of transplant we're trying to do. So the stem cells can differentiate into stem cells, and this is, can renew themselves into replicating into stem cells alone, and this is called their self-renewal capacity. And they can differentiate down to anything down their terminal pathways to become an erythrocyte or a platelet, and that's called plasticity. And this exists across the border in stem cells. So what are the challenges and barricades we have to treatment? So in order to find the best person who is going to be the best match for this patient, who must understand this journey, his or she has got leukemia, has got 4 or 5 months of intensive chemotherapy, is financially ablated, mentally ablated, physically, no questions, answers, feeling very low in life. And right now, somebody is not finding a donor, and he knows he's going to relapse in a couple of weeks to months, depending on the aggressiveness. So every 5 minutes, you have a new blood cancer, which makes about a little more than a lakh number of people every year. And about hardly 30% make it into taking actual care because it is limited by resource availability, geographic limitations, logistic, finances, insurance. And sometimes you just can't treat. Sometimes it's just too late to find them. So stem cells are often the last treatment option for survival because after the chemotherapy, they will relapse and you need to change the marrow. It's like laying a new field with new seeds. So you got to burn the marrow and put in a new donor who is matching. So only a third of the patients actually find a suitable donor in their family. It's about 25% tops that we've seen. That if you have 4 siblings, the chance of matching is about 25% with the remaining 3. So the compatibility is driven by what we call HLA, and the HLA stands for what we call the histocompatibility antigens, which take care of the kind of exogenous and endogenous monitoring of what kind of peptides come in and give them to the T cells, and we try and see what kind of responses are necessary. So the success of a stem cell transplant depends on the perfect HLA match donor. And we have a very different HLA because though we are one people demographically, we are many people ethnically, and we have a very large ethnicity pool. So if somebody in Tamil Nadu wants a match, somebody in Assam is not likely to be a match for him. But there are people otherwise in the Dravidian belt or in the upper belt, or people who move to other countries or other parts who could be easily a match if they could know that such a person is actually an HLA match to them. And the chance of getting that HLA match with siblings, like I said, the highest that we found was as about 15%, or if I give you an analogy like before, among 4, you could have probably 20-25% high chance. Patients search these stem cell registries for HLA unrelated donor searches when you do not find a sibling match. You don't have a haploidentical match from your father or mother, or this disease cannot be transplanted without a full match. Like for example, in aplastic anemias, we want a matched sibling over an unrelated donor or a half match. Also in diseases like thalassemia or sickle, which are not cancers, we don't want to give the patient the chance of developing the dreadful consequence of graft versus host disease, where that is a possibility. And you would want to try and minimize that effect because you can't take that chance in a sickle or a thal, as opposed to what you can take in an acute myeloid leukemia. So 36 million donors are registered worldwide, and less than 0.03% are Indians. And you need to know that this is one because of our mindset. We just don't want to give. And a sheer representation of that is because we have probably a more than 30% or 45% dearth of blood requirement, leave alone HLA matching for stem cell donors. The sheer population that we have, it's a shame that we don't have enough blood donors, leave alone these. So that kind of gives you a context of what our mindset is in terms of giving, well knowing that nothing's going to happen to you. So next slide, please. Sorry, I think I can't see it. Yeah. So there are multiple ethnic backgrounds or a diverse gene pool, which kind of concentrates into more than 20,000 ethnic groups that we know of, and we are not far behind from China or South Africa in terms of the ethnic profiling that we have in terms of HLA, and a minuscule Indian population in terms of the global stem cell registry representation. I hope after this talk things change. So like, you know about inheritance in terms of what the father and the mother bring in terms of what the child's blood group is. So this is a kind of a very simple analogy, which we all aware of the Landsteiner's groups of blood groups. And yeah. Hi, I'm giving a talk. So
How did you get that also?
Yeah, can I talk to you after some time? I'm having a talk.
After your meeting, can
Yes, you can.
you play that game that you have to pull our leg?
Yeah, I can. Yeah. Now give me 5 minutes. I'll come back. Yeah. Yeah, so you'll have to bear with my daughter who's here, so that's all right. I hope it's okay with you guys. So we have these blood groups, and you know how between AB and O the combinations can be with the child. So you have an A and an A mother and father, then you know it's very clear that you can have an A or an O, and an A and a B, and you know the options are A, B, AB, and O. Uh, and this analogy kind of is not as simple as it when it goes to HLA, because it's not bricks and banners there. It's whole or more of permutations and combinations. Next slide, please. So the HLA is far more complicated because
I'm feeling cold.
yeah, you need to go in so that can you please go in now? Because yeah, thank you. Yeah, you can tell mama. Sorry guys, yeah, you'll have to excuse me for that. So HLA is polymorphic. When you say polymorphic, is that 1 + 1 is not 2. There are a whole lot of combinations, and you really can't distinctly tell what happens. Classically, there are two kind of molecules in major histocompatibility: the class 1, the A, B, and C, and these are present on all nucleated cells. So RBCs don't have these. That's why you can transfuse them so easily, right? And class 2 are DR, DP, and DQ. Both of them are on chromosome 6 at different areas. And these class 2 and class 1 are different because class 1, the job is to kind of give the endogenous molecules to the T cell, and class two's job is to give the exogenous molecules to the T cell. Also, class 1 gets a cross representation of the exogenous, but what happens is class 2 is very interesting because most people don't realize that class 1 kind of internalize after their job is done from the nucleated cell surface, and they get degraded and they can turn into class 2 molecules carrying a whole lot of information. So in terms of histocompatibility in a bone marrow transplant, formerly called, now we call it stem cell transplant, because we no longer go to the bone marrow and drill holes as often as we did. We do that very, very, very uncommonly. And I'll tell you those situations later. So this is the isomer of the chromosome on the right side, and this is where the class 2 and class 1 are sitting. We would like as close a match as possible. We would like the exact A, B, C, BR, DP, DQ. That would be a transplanter's dream. Because if you have that, you know that these are genetically similar. The chance of them attacking each other is less because they will recognize each other as, looks like me, seems like me, smells like me. Okay, I don't want to kill him. And that's basically what we want. Right. So now you need to understand there is a host and there is a donor. So I'll explain to you how that works. First, let's try and see this very interesting slide about the father and mother and how their children, Gali, Paco, Nacho, Lily, and Chucho. I like Chucho, so I'll take Chucho. So if you look at Chucho, and if you look at the father and mother, can you remove the cursor from there, Mazin? Because I can't see that. You'll have to, yeah, remove your cursor. Right. No, I still can't. Okay, right. So the father on the left of your screen is got an HLA B and C on the top. Okay, and each of the numbers that you see are two representation of alleles on each of these. So HLA is A2A2, HLA-B is C5C2, and C is B5B7. Okay, and on the mother's side, you can see the complementary areas of alleles. So there is a representation of the ABC, which is essentially a numeric representation in terms of numbers as to where they are. And then there is the class 2, or the minor histocompatibility complexes. And they don't have extended numbers as you see here, because we want to see a half match first. Let's see if the 6 match, because class 1 is more important. Class 2 is less important, but terribly important, because certain kind of graft versus host disease can happen if you don't have certain class 2 mismatches. So we want to keep certain matches absolutely right, but primary is class 1. So let's see now what happens to Chucho, who's at the far right. So he has an A2C2B7. Do you see that? Now Chucho doesn't match with his father's, does he? But he does. He's got A2, he's got C2, and he's got B7 straight from his father. And he has from his mother A3, C4, and B7. Now, he is half from his father and half from his mother, like all of us are. And you can see the representation in Lily, which is all about the same, but in a different combination with the same kind of pair groups that you have from top. So we basically numerical matches, kind of turning around complex puzzles, but essentially this is what you are. Your genetic identity, no matter what you look like, is essentially just a couple of numbers. So if you see, now between these, sorry, you'll have to excuse me, 1 sec. Yeah, am I back on?
Yes,
sir,
yes.
we can.
Yeah, sorry, a couple of calls came in. My bad. So if you kind of see between Jelly and Paco, they have inherited the same ABC domains on the alleles as A2, C5, and B5, and they don't have similar alleles on the B on A2. C3 and C4 are different between Jelly and Paco, and B8 and B7. Now there are two mismatched alleles here. Do you understand? So Jelly and Paco are mismatched by each other by two alleles. So they're not the best. If you don't find a great match at all between a perfect match between two of these siblings, then it's unlikely. If Jelly is the person who gets cancer, needs a donor, and it's not going to get a perfect match with Paco. Let's say for some reason, but between Lily and Chucho, it's a perfect match. So the ABCs are almost exactly the same. And therefore, then we know that these two work, and then we initiate what we call a high resolution sequence. Right. So this is just expressing the class 1 and 2 alleles. And you can say the A, B, C. The top is the patient on the left, middle is the brother, and the other brother. So you're trying to find a match between the patient and the two brothers. And as math goes, you would see that there is a match between the first two, the first brother. They have A01, A01. Can you just bring that back, Mazin, so I can just show them what a low resolution looks like? So class 1 matches, class 2 matches, and here we have a good chance that if we initiate a further deep search for the other alleles, you notice here that we are just DRB1 right now. We don't have DPDQ, we don't have C. Go ahead, please. So that then we kind of know that there's a point in doing a high resolution match, which will give you a very extended sequence of the HLA. Now you see this patient has beta thalassemia major, which is a transplantable disease and is not a malignancy. Now this is the mother, and you can see the A, B, and C loci. We're going to highlight her in red so that you can understand how the father and the mother's blue mosaic comes through together. So A, B, C, DR, DP, DQ are very clear. Now, if you notice, DR has further allelic segments, B1, B3, and B4, and B5, and these come in extra in the high resolution. What Mazin just kind of highlighted is the top one, which is the patient. Mazin, can you go back to the last one when you highlight the top, please? So you see that this is a mosaic of the mother and the father, and now you have a permutation for which you must find a donor, which is ABC, almost complexly divided, and there is no logic as to what kind of combination is going to come. It just so random, as random as life is. Right. So if you see how, yeah, I can't see that. This is the representation from the father and the mother into the patient. Next slide, please. And if you see C as well, the same. Right. So what are the steps to become a lifesaver? Now, Mazin, are you going to do this, or this is my bit?
Okay. So before I continue, thank you so much, Dr. Govind, for the explanations. That's really impeccable. And Salman, could you check on the waiting room? There are a lot of people who have nudged. Thank you. So for those of you who have heard about all the explanation that Govind have mentioned, so let's talk about what is the eligibility criteria in case you're signing up as a donor. So you have to be an eligibility criteria that you are healthy adult, you do not have any of the diseases of the visceral organ or related to blood disorder or autoimmune disorder, and that you're living in India, a healthy adult between the age 18 to 50 and not registered with any other stem cell registry. So for the first step, if you're registering with us, you will be given a link, an online link basically, and you will be registering online on a web page. And once you fill up your consent form, you will be getting a cheek swab. It's basically a cheek swab, like a cotton bud, to take the samples of your cheek swab. So basically it is to understand your HLA typing. So once that is done, you will be stored in the database until your 61st birthday. And step 2 and step 3 only comes in when if you're a match. So that match can happen maybe within a couple of months, or maybe it can take a couple of years, or maybe decades. So when I say decades, yes, there are people who have found match after 10 years or 20 years being in the registry. So when you're coming into step 2, so basically what is done is a small vial of blood is extracted from you to understand whether you are a perfect match, and the samples provided by you earlier is a all across match with the patient, just like how Dr. Govind was explaining about the HLA. This has to be matched. Once that is done, you will be going through the step 3. So the first step of step 3 is the medical checkup. So why we're doing this is basically to understand that you do not have any other disorders or anything that could harm yourself or the patient in the future. And this is also because when you are signing up now, maybe if you come up as a match, maybe years ahead, maybe decades ahead, there'll be a lot of changes in your body, and because of the lifestyle and everything. So to ascertain whether you are still a perfect match in terms of medical eligibility, you'll be going through a medical checkup. And once you are cleared from the physician, then you go through the donation process, which I'll be explaining in the next slide. Once that is done, you will be the collected stem cells will be then transplanted to the patient. So the process of donation is quite same. It's very simple to a platelet donation or a plasma donation. So you will be drawing one needle on the arm where blood will be extracted, and will go to the process called apheresis, where the blood units are separated into components as RBC, WBC, etc. And only the stem cells will be extracted from this, and the blood goes back into the body. So to induce or to mobilize stem cells into the bloodstream, you'll be given an injection called GCSF, and this will be for 5 consecutive days to basically mobilize. So Dr. Govind will input certain points for your information.
Right. So stem cell is no longer drilled into the bone marrow and brought out anymore. We do a peripheral blood stem cell harvest, which is called a PBSC for short. And it's a very simple procedure. So if you've ever been a blood donor, you're kind of aware of this machine, which is a a chemoanalyzer. It kind of centrifuges the components depending on what kit you place on it. If you want neutrophils, we take neutrophils. We do granulocytic transfusions for AML when they have infections. We do different kind of component separation. So stem cell is just a component. And if we mobilize enough stem cells into the peripheral blood, where they're generally not there, they reside in the marrow. So like Nazeen said, we give you some colony stimulating factors, which are like molecular scissors. And these scissors basically will cut and cleave the stem cells and ask them to please come out into the blood, where they can be very easily harvested by a simple venipuncture. You don't even need a dialysis catheter or anything else. They go into the ultracentrifuge in the old component therapy machines, and they are removed by fractions. Now we do it by electric charge and gating. We have CD34 markers for the stem cells, and selectively CD34 positive cells or the large mononuclear cells are removed and put into a small bag. It's such an anticlimax by the end of it, because it's just a simple blood donation process. You don't have any pain during the procedure. However, when you take the stem cells, when you take the colony stimulating factors, you may have some pain, which is an indication that the bone marrow is expanding and you're actually going to give them good stem cells. This is very amenable to paracetamol, and you will have no discomfort for more than a day. Also, the other thing I want to imply is explicitly is that there is no long-term problems due to stem cell harvest by this manner. Your stem cells will renew very quickly within a few weeks, and you will be absolutely up to speed. And during the procedure, we do use calcium so that the blood doesn't clot in the form of citrate. And a lot of citrate is not given. However, some people may have hypocalcemia when it gets leached into the system and the citrate is used. So we do give calcium supplementation IV during this process to prevent any kind of hypocalcemia. And this usually doesn't happen. So it's done within a day usually, or if you get good stem cells, there's a yield that we look for. We look for at least 2 into 10 power 6 cells per kg body weight of the donor, not of the patient, of the donor. And that is the trick. So if you are a 60 kg person and the donor is 70 kg, you might need to give in a little bit more, which might just mean one more cycle and you wouldn't understand the difference. At the end of it, it's all done. And essentially, that's what the donor looks like with a pretty stem cell bag in his hand. And it's so simple, and you feel so empowered because this is the only kind of transplant organ that you can give away and still live and meet the donor. You can be Superman while you're still alive. You don't have to go crash into a bus so that your lung, liver, and heart are taken to 6 different people. Over time, you might be even able to meet the donor after the legality clause of 2 years is done. So it's a very simple procedure, 3 to 4 hours, max 2 days, and it's very safe. And there should be absolutely no reason as to why you should feel that there'll be any long-term damage to the donor.
Thank you so much, doctor, for the explanation. So basically, how he have mentioned is quite easy, and there is now that you know the process is quite easy, you have to wonder why people just turn away, because most of us has the opportunity, just like how doctor have said that we would have the opportunity to save somebody, but we just walk away because of many factors, skepticism or doubt or confusion, or simply that thinking that it's not a problem. But when we ignore and walk away, we might lose the opportunity to save someone in need. For us, it is just a lost chance at saving a life. But for that person, it can be their last chance to live. So when you see there are like countless patients who lost their life to blood cancer. And I would like to play a video where an appeal of a parent who lost a child. And this is a real video and a heartfelt request of a parent that no one should lose a life just because there is no match.
Ayush was a very active and a very energetic child, always very inquisitive. He always liked to learn things very quickly. He was very interested in music from his childhood. He always used to talk about, Mom, I want to get into army, I want to do something for the country. He used to love his brother, they used to play a lot together. He has won a lot of awards and medals in his sports. He had lots to achieve in his life, but I think life had some other plans for him. He was diagnosed with blood cancer in the year 2016 when he was 11 years. And from then a lot of treatment and stuff started, and Again, it relapsed in the year 2019.
Only when Ayush was diagnosed with blood cancer did we realize that in India, every 5 minutes somebody is getting diagnosed with blood cancer. Doctors advised us for a stem cell transplantation, and that was a time when we got a shock of our life. That in a country of over 1.35 billion people, we could not find a perfect match. And that was primarily because there was a lack of awareness amongst people to come forward and register.
Since Ayush didn't get his match, I think we were not able to save him. I wish that a lot of people should come forward and register themselves in the stem cell registry at DKMS BMSD.
Had we found a perfect match, Ayush would have been alive. I therefore urge you to come forward and register as a potential stem cell donor.
You can make this difference by registering as a lifesaver. That there are so many Indian patients across the world right now in search of their savior. There are patients like Abir and Nazmeen, Kriti, Arya, Anant, Veer, Juhit, and Niti. You can make a difference by registering as a potential lifesaver, and this can actually save their life. So remember that the person in the video said every 5 minutes someone in India is diagnosed with blood cancer. The only thing that keeps them going is a hope of finding a matching donor. So you can actually make a difference by registering as a potential lifesaver by registering voluntarily. So when I say voluntarily, it's completely with your own accord and there is no compulsion by any means. And when you register with us, we are obliged to follow certain rules and regulations that your data is completely safe and it's protected. So we follow the World Marrow Donor Association's data privacy standards, IT Act of India, General Data Protection Regulation, and we clearly do not share this private information to anybody. So what information is being shared across transplant physician is the HLA, donor ID, gender, age, and the status of availability. So when a patient is looking for a match, the treating physician looks in the data registry or a global registry, and this is the only information that is available for the physician. And the physician makes a request to a respective registry, and the registry calls this donor to further communicate and do the process of transplantation and all those things. So for as an easy explanation, there's 3 steps that you can easily do: register, swab, and save a life. Registration link will be shared in the chat window within few moments. So it's easy process where you can just click in and you can see if you're eligible, fill in up your details, and once clicking submit, within few days to a week, you'll be receiving a parcel or a courier, which will contain these documents for your information. And also in the kit, you will receive these items, except the donor ID card, which is the left-hand corner. So you will receive this swab kit, the buccal swab envelope, and the business reply envelope. So you will have to just simply swab using the swab kit and send it across any post office here in India. And within few weeks of registration, you'll be receiving your donor ID card. So it's a simple and easy way how to swab. You can check the YouTube link for instructions how to swab. Basically, you're collecting loose tissues and not saliva. This loose tissues is basically to denote what type of HLA you have. And this will be stored in the database till your 64th birthday. And once again, I am emphasizing this is only the step 1 that you're doing now. You will find a match anytime in the future, but now you're only registering by doing a swab, and this data will be stored in the global registry until your 64th birthday. And whenever you come up as a match, then only you will be needing to donate. So Dr. Govind will walk you through certain myths about blood stem cell donation and its clear facts.
Yeah, thank you, Nazim. So the myths are that I can donate only once in my life. That is not true. When we seem it necessary, we can be multiple donors through our lifetime. As a very extreme case, I remember a donor being used twice in a period of 2 years. I mean, that's absolutely normal. And peripheral blood stem cell is a surgical procedure. So like the entire slideshow is elucidated that it's a very simple blood donation process and it just takes a couple of hours and it's a purely medical procedure. Stem cells lost during donation cannot be replenished is the next myth. And this is also untrue because stem cells replenish. There is a supply mismatch mechanism of self-regulation, which kind of kicks in and you have your stem cells up in a few weeks. Usually, statistically, within 6 weeks, most of the recovery is already done. And you don't feel absolutely any difference after the stem cell donation. Smoking and drinking makes me unfit to register. This is also untrue. You can be a matched unrelated donor if you smoke or drink. It just depends how healthy you are, and we'll figure that out if you ever turn out to be a donor during your medical examination. So this is something that is important to understand as to what these stem cells are going to do in the patient. So these stem cells essentially have to get in and have to lay down into the marrow, and they have to start producing all the repertoire of blood cells that are available. So when it's a donor going into a new patient, you need to be aware that these stem cells are essentially going into a place which will have some resistance because the host immunity has to be suppressed. So we give them immunosuppression so that the host is absolutely immunosuppressed and doesn't put out or mount an rejective approach against the new donor. No matter how ISO typed you are and how HLA identical you are, you still have, even in a full match, about a 10% and as high as even 12% to 15% chance of a graft versus host disease reaction. Now, what is that? So the graft is the stem cell. And if you imagine the graft has to work against the leukemia, and you want the graft to work against the leukemia, the new donor stem cells to kill the leukemia that are present and what is microscopically evading the previous host's defense. Unfortunately, the way this works is that the graft looks at what is dissimilar from it and starts destroying it. So the leukemia is absolutely different to it, it will destroy it. And that's called the graft versus leukemia effect, or GVL. However, with a degree of mismatch with the donor, you might have a graft versus host disease, which is essentially diametrical poles of the same spectrum of activity. So that's why we need absolute matches, because there is a big chance that despite you controlling the disease, you might have very severe non-relapse mortality, which is graft versus host disease. So we want as HLA identical people to come through, and that comes through only if the ethnicities match. So yeah, so your registration journey, as Masin has already explained to you, is week 1 to week 12. You know what happens through this. But what I want to emphasize is that you can back out anytime. There is absolutely no reason or compulsion that even if you become a match and you get a phone call, you take a call, what you want to do then. If you say, no, I don't feel comfortable doing this, nobody's going to hold you to it. And if you're a minor and this happens, you can always talk to your parents and they can be talked to. Usually what happens in our system is that people kind of discourage you. Nahi yaar, ye mat kar, chhod. I don't want you to go to trouble. Who knows what happens? Nothing happens. So please do this and, be a Superman. Come on. This is what we need. We need more people to come out, and we want Indian ethnicity to be filled in the registries. So we just run down the summary bullet points.
Thank you so much, Dr. Govind and Mr. Mazen, for addressing the seriousness and the urgent need to create awareness about blood cancer and stem cell donation, and also enlightening our members about blood cancer. So we'll quickly start with the Q&A round, and we had received 2 questions before, so I'll quickly address them first. The first one is, how should we screen the general population effectively for blood cancer?
Yeah, the incidence of blood cancer is, though at the rate of being, diagnosed 5 a minute, it's actually a small, minuscule population in terms of the larger healthcare burden of the disease. So routine screenings are not going to find it. And the way to do it is to be preventive about your lifestyle choices rather than trying to look for blood cancer. And then, of course, you find somebody from a medical checkup and, incidental illness all over the place. But responding to symptoms is probably what happens in blood cancer. Fever that's not diagnosed for more than 4 to 7 days, 14 days, recurrent boils, infections, swellings. People don't take these things very seriously, actually. So you'd actually get a whole lot more if you would just get symptoms to the right kind of treatment strategy module.
All right, thank you so much, sir. And the next question that was asked before is, what are the possible palliative care methods surrounding blood cancer?
Yeah, that's a very good question. Right, so we're going to the entirely opposite spectrum from aggressive transplant to palliation. It's a largely unmet need, not just in blood cancer, but even otherwise for the burden of palliative requirements across the country. There are a few centers that are an excellent staff. For example, the district in Malappuram has a very, very extensive palliative care program funded by different entities run by the medical college system at Calicut. So there are programs which need to be done like this, and largely it's very unmet needs. Palliative care programs are very minimal. The kind of quality care and pain alleviation that is possible is probably not being met to even 50% of the patients that are suffering from different types of cancers. In terms of blood cancer alone, palliation is really essentially watching the patient wither away in front of your eyes, because what happens is that he will become anemic, he will get neutropenic, and he will bleed out at one point in time. So palliation doesn't happen usually in some hospital, because most nursing home palliative options are not comfortable managing a patient like this, because it's not very easy for them to handle it. So the maturity around palliation for a leukemia is, I think, largely driven by finances. When you can't do anything, you just stop doing stuff. Like finally, in a patient who's been on a ventilator for like 3 months or something like that, you just run out of cash. So they die quick. Palliation is not more than a few weeks to a month, but there are patients, who go on for some time and, get. So palliation largely is doing nothing but symptom management. But when palliation involves blood transfusion and maintenance, hemodialysis, and giving antibiotics, it's truly not palliation. It's just keeping the ball running, and that's basically what happens in our country. Kuch to kariye, sir, like just kuch to kariye. So that's basically what happens. But for a mature palliative decision, the answers are simple. You don't even give fluids. You just support, counsel, and bring that process wherein palliation becomes an option sometime between the journey. It shouldn't be suddenly like aap kuch nahi kar sakte. So when you start sensing that this is not going well, I think it's your duty bound to kind of make that decision. You're playing like the manager for the field. You're making the financial decisions, emotional decisions. Of course, you're making the clinical decisions. You're running your own team. So there are a lot of issues which you need to be very clear about when you handle any patient, leave alone leukemia. What are you doing that's going to change his life? Is the risk benefit assessment worth it? Is he going to be on the streets because of this decision? And I think you have to constantly keep asking yourself that, because you're going to burn a hole into every pocket that you're going to treat. Absolutely.
Thank you so much, sir, for such an elaborate answer to this question. We'll wait for 30 more seconds if we receive any other questions for now. We do have a question that just came up. What category of blood cancer patients must require a stem cell transplant?
Thank you. Now I can talk about bone marrow transplants a bit. So yeah, so let's look about risk stratification in leukemias. I think the question is pertaining leukemias, isn't it? Yeah. So AMLs and ALLs largely end up being transplanted. The pediatric population sees a whole lot more of ALL than the adults do. And in their treatment module is very aggressive, and we do very well in treating them, and they don't generally end up requiring transplants because their cure rates is about 70% in the right hands, sometimes even 75 to 80. Even our data down south is just brilliant with pediatric transplants. I mean, pediatric ALL management. The same when the happens to the adult ALL is not that great because the risk kind of goes up, and you have a generally a pH positive population which requires transplants of ALL of the adults. And the adult ALL is not that great because very few are low risks. We generally have bad mutations, and we do risk profiling when we diagnose the patient. We do a karyotyping, we do a FISH mutation analysis to see what kind of cells expressed on this blast, and therefore what ammunition can we use. For example, in the treatment of AML, if you see that this is low risk, doesn't require a transplant at all. In version 16, you have a lot of good markers which don't kind of need you to do a transplant, but you have to be watchful expectancy and make sure that you're counseled well. Of course, intermediate and high risks need transplant, and that's a large chunk of the AML population. So they end up generally being in transplant after they undergo induction therapy and consolidation. And by that consolidation of 3 months, you need to find a donor. They'll go straight to transplant if they're low risk and they're in induction failure. So, or if they're intermediate risk and they have an induction failure, or they have complex cytogenetics, or they have high risk markers like FLT3 ITD, very high internal tandem duplication burdens. If you have these kind of patterns, we kind of know that this is not going to go well. We must talk to them about transplant right away during the initial induction therapy, because you'll get these answers within about 10 to 14 days of doing your bone marrow. So slowly talk to them about risk, because by then generally you've started some therapy. And those are the high risks that need to be sorted out early, and not all of them require transplants.
All right, sir. Thank you so much. We'll take one last question. Can there be any issues in HLA typing in case the technique of cheap swab is incorrect? And yeah.
Yeah, so I'll rephrase the question. Is there going to be a pre-analytical error because of the way you swabbed the cheek swab? Is that the question? Okay.
Yes.
So it comes with a very simple instruction. You just need to get the cheek swab done in a very simple manner. You don't have to rub it too hard. Just make sure that the mucosa that's got all those ends, near the Watten's duct, just kind of give it a nice rub there. And you generally don't get false positives for the low resolution at all. And you don't really have a large pre-analytical gap because we've been doing this for so many years, and you standardize these procedures. I think you're underestimating what the cheek can produce. The cheek is a very heavily antigenically armed organ. It's got a lot of cells sitting there. It sees the bulk of the muck all the time. You should be aware that the anus is not the dirtiest part of the body. It's the mouth. That's why we give free antibiotics before you do any surgeries on the heart, and not while you're having pile surgery. So the cheek is seeing so much. That's the mucosa which is seeing so much. The food, the different bacteria, fungi, viri coming in all the time. So it's a very antigenic organ, and it expresses things beautifully.
Thank you so much, sir. And with this, we can end the Q&A round and proceed towards the end of our session. I'd like to thank both of you for taking the time to join, and it's a pleasure to have you with us this evening. And to the participants, I'd like to thank all of you for joining us for the webinar and celebrating Blood Cancer Awareness Month with all of us. I will be sharing the post-webinar form right now in the chat box, and you can fill up the post.
There's also form. One more, just one more video,
yes.
And then we can do the vote of thanks. Just one more video.
Blood cancer. 2 words जो हम सभी ने सुने हैं. But how much do we know about it? Every 5 minutes, someone in India is diagnosed with blood cancer or other blood disorders. In fact, over 1 lakh people are diagnosed with blood cancer in India every year. Only a blood stem cell transplant could give them a second chance at life. However, finding a matching donor is extremely rare. Why? because of social stigma and taboos. These taboos are destroying families, taking away any chance of hope from these patients and their families. For those who don't know, besides being an actor, I am a family man first. To me, family is everything. And seeing other families struggle to keep theirs intact is truly heartbreaking. That's why I urge you to come forward and register with DKMS BMST and help give a family a chance to save their loved ones. Just a few minutes of your life could add many happy years to someone else. Take it from me, it is worth every minute of your time. Join our community of lifesavers. Join me in the fight against blood cancer. After all, it's in your blood to save a life.
শিয়াশা 2015 সালে জন্মায়, তখন সে সুস্থ সবল ছিল। তো একদিন এইভাবে যখন তার বয়স 9 মাস, তো ডাইজেস্টিভের সমস্যা হচ্ছিল, ডিসেন্টারি হচ্ছিল, তো লোকাল ডাক্তারের কাছে আমরা যাই। ডাক্তার কিছু ওষুধ দিলেন। নেক্সট দিন, পরের দিনে আবার প্রচণ্ড হাই ফিভার হয়। ডাক্তার দেখে বললেন ইমিডিয়েটলি একে অ্যাডমিশন করাতে হবে এবং বিভিন্ন রকম টেস্ট দিলেন। থ্যালাসেমিয়া টেস্টও তার সঙ্গে দিলেন। ওর থ্যালাসেমিয়া পজিটিভ এলো। আমাদের তখন মাথায় পাহাড় ভেঙে পড়ল।
আমরা চেন্নাইতে গেলাম, ওখানে শুনলাম যে এর পার্মানেন্ট সলিউশন আছে। আমরা খুশি হয়েছিলাম যে স্টেম সেল ট্রান্সপ্লান্ট করার পরে ও নর্মাল লাইফ লিড করবে।
In the year 2015, I came to know about the stem cell drive that was going on at my office, conducted by DKMS BMST. There was a poster, Donate and Save Life, which really inspired me to go ahead and register, because my mother was initially diagnosed with first stage cancer, so I can really feel the pain that one goes through. So it really motivated me to go ahead and register as a potential stem cell donor.
ওপরওয়ালার ধন্যবাদ যে আমরা 1 বছরের মধ্যেই আমরা আনরিলেটেড ডোনার 10-on-10 ম্যাচটা পেয়ে গেলাম।
After 1.5 years later, I received a call from DKMS BMST saying that you found to be a potential match for a patient. I was really glad at that moment, because not everyone gets this chance of saving life.
এর জন্য যে ডিকেএমএস বিএমএসটি সংস্থাকেও ধন্যবাদ জানাই।
If I get chance, I will definitely donate once again, and I will strongly encourage each and everyone to come forward and register as a potential stem cell donor.
ডোনারকে আমি অসংখ্য ধন্যবাদ দিতে চাই। তার প্রতি আমি চিরজীবন কৃতজ্ঞ হয়ে থাকব। তার এই সেল নিয়ে আমার মেয়ে আজ সুস্থ সবল হয়ে আছে। সে আজ স্কুলে যাচ্ছে, খেলছে, বাচ্চাদের সাথে পড়ছে, সব সময় ঘুরছে ফিরছে, নর্মাল জীবন যাপন করছে। এই জন্যে আমি এখন গর্বিত এবং আশ্বস্ত যে এখন আমার মেয়ে সুস্থ আছে।
Please welcome on stage Debjyoti Banik.
I'm like completely overwhelmed and really glad. It's a lovely feeling. I can't really express in words.
अभी हमारा ज़िंदगी में ऐसा लगता है जे सब कुछ मिल गया। जब हमारा बेटी सुस्त है तो हमारा जीवन में और कुछ असंतुष्ट नहीं है।
Thank you so much, everyone, for joining us this evening. On behalf of Medical Students Association of India, I'd like to express a heartfelt thanks to Dr. Govind sir and Mr. Mazen sir for addressing us about blood disorders, donation process, HLA, and the challenges surrounding stem cell donation, and highlighting the need to create awareness about blood cancer and stem cell donation. It was a pleasure to have you on board for this webinar. And thank you so much once again for celebrating Blood Cancer Awareness Month with us. And with this, we can conclude today's webinar.
Thank you so much. Thank you, guys. Thank you for
Thank
the
you so much.
opportunity.
Thank you so much, everybody.